I just got a reminder to record there. Yeah, so this morning we'll be having a presentation given by one of my co-fellows, Dr. Marisol Lolas, and moderated by my colleague, Dr. Joana dos Santos, who's right next to me over here. Marisol will be giving a talk on hematuria. Just a reminder that there is a Q&A block, so if you guys would like to ask questions as we go along, please feel free. There'll also be some time for questions afterwards, and we'll get some of our staff surgeons to chat with you guys afterwards as well. This meeting is being recorded, and we will also send out a questionnaire for evaluation of the meeting afterwards. Yeah, thank you, Marisol. Please go ahead.
Okay. So hi everybody, I'm Marisol Lolas. I'm one of the clinical fellows here for anyone joining this meeting that is not from Sick Kids. So today, as part of our Friday morning academic sessions, we're going to be talking about hematuria. And special welcome to our international guests, if there are any today. And the talk will be presented by me and by Dr. Dos Santos. There, okay. So to start with, as you know, hematuria is usually commonly divided into microhematuria and gross hematuria. And so just to be clear, in children, microhematuria is considered when there are 5 or more red blood cells per high power field, ideally on 2 consecutive samples of freshly voided urine. And this is different from the value used in adult population, where the number is 3 or more red blood cells. And then gross hematuria is just the one that's visible to the patient or the caregiver, simply. So for today's presentation, I will be talking broadly about hematuria to start with, but then we will focus mostly on gross hematuria, as given that this is more relevant in the context of urology. Okay. So first of all, the assessment of urine usually starts by the use, well, hematuria usually starts by the use of a dipstick. And the dipstick uses hydrogen peroxide as a reactant, which means that it identifies heme, not only blood. This means that a positive dipstick for blood in urine is mostly likely due to blood, hemoglobin, or myoglobin in the urine. And in some situations, such as oxidizing agents, alkaline urine, some bacteria, betadine, or ascorbic acid, can warrant the possibility of false positives. A negative dipstick, however, does eliminate the possibility that these etiologies are behind the hematuria, right? So then further assessment of the urine involves urine centrifugation. If after the centrifugation the sediment is red or brown, then the etiology is most likely blood. If the supernatant is red or brown and the sediment is clear, then the red and brown urine is not due to blood, but to other substance such as free hemoglobin or myoglobin. And finally, if the urinalysis is positive, it's ideal to perform a microscopic examination of the urine. Okay. And the urine microscopy, which is done if the urinalysis is dipstick is positive, assesses the urine sediments and should be assessed for the presence of things that would suggest certain etiologies, such as crystals suggesting lithiasis, leukocytes suggesting UTIs, red blood cell casts, or dysmorphic red blood cells that would orient us towards glomerular disease, right? The same goes for proteinuria. Some of the false positives that we can find in the assessment for proteinuria are shown in this table. So we have talked about the hemoglobin and the myoglobin before, but also many drugs such as phenazopyridine and rifampicin, that's used for TBC, can produce dark orange urine. Beets, blackberries, and some food coloring can result in tinted urine too. And some of the metabolites, such as porphyrin, can give urine a darker tint. Also, one thing that we have to consider is also always factitious hematuria in the context of Munchausen syndrome or Munchausen by proxy, especially in the case of children. So I found this interesting. There's a lot of different colors of urine that you might encounter. I just basically put this here because I found it interesting. But the main thing that we have to remember for the context of hematuria, I think, is that grossly bloody or red urine is usually from a non-glomerular source, and well, within those sources, the presence of clots usually indicates a lower urinary tract source. And on the other hand, more brownish or tea-colored urine usually suggests a glomerular cause. Sorry. This is another slide showing a more prettier display of different colors of urine. So moving on to hematuria in children, that's the topic of our talk. The incidence of detecting blood in the urine is usually ranging from 0.5 to 3% of the general population. And isolated microscopic hematuria is usually a benign condition, and it can be confidently diagnosed with relatively simple histories and assessments have been accomplished. On the other hand, asymptomatic gross hematuria is more likely to result in urgent referrals and a more aggressive evaluation, right? Sorry. The causes of hematuria in children can be divided using different classifications. One of the most popular ones are the classification between micro and macroscopic hematuria. Some of the etiologies can cause both micro and macroscopic hematuria. Sorry guys, I spilled some water here. Oh, sorry. For macroscopic or gross hematuria, the number one cause in children tends to be hypercalceuria, with glomerular nephritis and benign urethra regia coming in a close second. Another one of the classifications that we can use is the one based on where the origin of the bleeding is. And this can be glomerular, that includes all of the glomerular nephritis conditions, interstitial, lower urinary tract, and vascular. And then the AUA has this ABC classification of the causes of hematuria in children, where A is for anatomic abnormalities, B is for boulders, meaning hypercalceuria or stones, C is for cancer, D is for drugs, E is for exercise and trauma, F for familiar causes such as Alport syndrome and familial benign hematuria, G is for all the glomerular nephritis, H is for hematologic such as sickle cell or coagulopathies, and I is for UTIs or infections. So the initial assessment for the child with hematuria, regardless of the consulting service, a thorough physical exam and a well-detailed family and patient history is needed. And in the physical exam, it's important to look for signs of suggestive of glomerular disease, which would be such as edema, indicating maybe the presence of proteinuria indirectly, hypertension. Also a low BP, on the other hand, could suggest trauma or massive blood loss. The abdomen should be examined looking for masses suggestive of tumors or enlarged kidneys. Skin should be examined in search of rashes, impetio, orienting to post-strep glomerular nephritis. Also, some findings of purpura could lead to further investigation of vasculitis, lupus, Henoch-Schönlein, and IgA nephropathy, for example. In the patient history, a new onset of lower urinary tract symptoms could suggest an underlying UTI. Recent history of GI or respiratory disease could orient towards glomerular nephritis. History of intermittent flank pain could be suggestive of stone disease or Nutcracker syndrome, where a family history of stones should also be relevant for the stone disease. The timing of hematuria, for example, is also important. Initial hematuria usually suggests urethral bleeding, while terminal bleeding usually suggests some bladder disease. And then continuous bleeding throughout the urination may be originated well in the bladder or the ureter or the kidneys. It's also important to look for a history of predisposing clinical conditions such as sickle cell disease or coagulopathies that can be part of the patient history or of the family history. And some of the pre-existing conditions can also cause hematuria indirectly because of the medications that can cause false positive, or for example, some like cyclophosphamide or NSAIDs that can cause hemorrhagic interstitial cystitis. So finally, we'll focus now on gross hematuria in the pediatric population. And gross hematuria for kids is very rare, and it accounts only for around 1.3 out of 1,000 patient visits to the emergency room. And an important thing to highlight is that unlike adults in whom gross hematuria carries a much higher likelihood of malignancy, medical renal disease is the most common cause of microscopic and gross hematuria in children. And therefore, the role of the urologist is very different compared to the role in hematuria in adults. Moreover, a significant number of children will not have an identifiable cause, and that's important to remember. And this translates into many controversies, both in evaluation and management of these patients. So I have a couple of papers here showing the distribution of the causes of gross hematuria in the pediatric population. This first one is from 1977, but it's cited in every single publication about gross hematuria in children. It's a retrospective review of all patients in the emergency ward in the span of 2 years. And out of the 128,000 patients seen, only 150 had gross hematuria, showing the incidence that I mentioned earlier of 1 in 1,000. And from all the children with the gross hematuria, a little bit over half had identifiable causes. Almost a third of them were UTIs. Around 10% had glomerular disease, and no etiology was identified in 10% of the patients. However, it's important to notice that there was another 23% that were treated as suspected UTIs, but they never obtained confirmation. So this study places UTIs as their #1 cause for gross hematuria. It is possible that this is due to referral bias, given that this is an article from the Pediatrics Journal, so maybe the focus is a little more medical. And well, in the second figure on the right, we can see that the peak age of presentation for them was 3 to 4 years old. Sorry. So in this review, am I on the correct page? Yeah. 711 of the visits to the ER were diagnosed as UTIs. And only 10% of them had the associated gross hematuria. The presentation of gross hematuria in the context of a UTI was more common in females, in a ratio of almost 4 to 1 compared to males, for confirmed and documented hematuria, that is. And trauma, meatal stenosis, and recurrent gross hematuria was more predominant in males. This is another paper. This is a retrospective study from New York that followed 342 patients over a 10-year period between 1994 and 2003. 80% of the population were boys and 20% were girls. And among the causes of gross hematuria, 19% were benign urethral regia. An equal 14% were for trauma and UTIs. Of the UTIs, 10 of those had also concomitant urological anomalies. 13% of the whole population had congenital urologic anomalies as the underlying cause for hematuria. Of these, the main one was reflux, followed by posterior urethral valves, UVJO, hypospadias, UVJO, urethrosil, and one case of calyceal diverticulum. Only 5% of the population had stones as an underlying cause, and only 1% had malignancies. The malignancies found were 3 cases of low-grade bladder transitional cell carcinoma and 1 case of Wilms tumor. In this paper, and this is stable compared to the rest of the literature about this topic, around 30%, so 34% for this paper, had no identifiable causes whatsoever. It's important to know for this case that no viral cultures nor calcium creatinine ratios were routinely obtained looking for viral cystitis or hypercalceuria, and no routine cystoscopy was performed. So it's also interesting to note that in this review, there were very few cases of glomerular disease identified, probably again due to referral bias, given that this paper is a more urologically focused paper. So these are the results from this paper. And we can clearly appreciate that the presentation of gross hematuria is always more common in boys than in girls, regardless of the etiology. And the first figure on the top left corner, we can see that the distribution of girls and boys by age. In this series, the peak age of presentation is closer to the teenage years in boys, while in girls, it's more similar to the previous study. Figure number 2 shows that most of the trauma-associated hematuria in girls was from renal and bladder origin, with very few urethral lesions, which makes sense given the anatomy. In figure 3 on the top right corner, we can see that of those patients who had UTIs, the vast majority of them were between 3 and 12 years old. And in the last figure on the bottom right corner, we can see that reflux was by far the most common underlying anomaly of the urological anomaly associated with gross hematuria. So other of the interesting findings in this paper were the symptoms at presentation. 30% of the patients presented with lower urinary tract symptoms when voiding. And of those patients without a history of trauma, around half had either abdominal and or flank pain. 17% had lower back pain and 13% had suprapubic pain. Also, out of the 8 kids that presented febrile out of the population on this paper, only 3 had actual positive urine cultures. Then this is a very important question that was commented in this paper, which is to scope or not to scope. For this population, around 40% of the patients got cystoscopies. And although they did find positive results in almost half of them, the authors do report that for most cases, cystoscopy was not necessary and did not change the treatment or management whatsoever. Many were only performed to satisfy anxious parents or referring physicians, or to reconfirm diagnoses that were already suspected or known, or to confirm the absence of an obvious etiology. It's important to notice that the 4 malignancies that were identified in this series, 1 Wilms tumor and 3 bladder carcinomas, which accounted for less than 1%, were all previously identified by the initial ultrasound. So cystoscopy was not needed to make that diagnosis. This goes to say that cystoscopy should probably be reserved for persistent hematuria without etiology, or those with very obvious abnormal imaging. Oh, I'm sorry, and also other reasons behind that would justify cystoscopy will be angiomatous malformations of the collecting system, the Nutcracker phenomenon, and maybe factitious hematuria for final confirmation. We will go over these etiologies later in the presentation. So here I added 2 treatment algorithms. The first one is for Campbell-Walsh, and I won't go over the whole algorithm, but it's just to show that both Campbell-Walsh and the AUA, whose algorithm I will show next, both agree that cystoscopy should be saved for cases of persistent gross hematuria. In the case of Campbell-Walsh, they suggest for persistent hematuria for more than a week, or recurrences. And in the case of the AUA guidelines for hematuria in children, they recommend cystoscopy for for recurrent gross hematuria or persistent lower urinary tract symptoms, or ultrasound findings concerning for renal bladder lesions that need to be further investigated. This is the third and last paper about the same topic. This was done in New York, and it's a retrospective study done in a pediatric nephrology referral center. So it was expected to have bigger proportion of glomerular disease, sorry. They looked at the medical records of 100 patients followed for gross hematuria between 1992 and 1999, out of which only 82 patients had a complete clinical evaluation and were included in the actual paper. The findings revealed that almost a third of the cases were of glomerular source, being IgA nephropathy, Alport syndrome, and post-strep glomerular nephritis, the first cases. The most common cases. And another third of the cases were attributed to glomerular causes, being hypercalceuria #1, but followed very closely by urethra regia and hemorrhagic cystitis. Finally, we can see again in this study, such as the previous one, that around 30% or a third of the cases of gross hematuria in children were of unknown etiology. In this case, in this paper, they pointed out that the 26 out of the 28 patients with unknown etiologies were considered to have a non-glomerular source for the bleeding. So now we will go into some common etiologies that we will find in our practice as pediatric urologists. The first one is the most common one, hypercalceuria. Hypercalceuria is the excessive excretion of urinary calcium, as the name says, and it is, the range considered is more than 4 milligrams per kilogram per day, or more than 0.1 millimoles per kilogram per day of calcium excreted in urine. It can be caused by excessive GI absorption of the dietary calcium or excessive sodium intake and renal leaks of calcium due to the decreased tubular reabsorption. The hematuria that presents with hypercalceuria is usually caused by mechanical trauma to the renal cells done by the calcium crystals, and it's usually painless and can be micro or macroscopic. Patients with hypercalceuria are also at much higher risk of developing nephrolithiasis. So this paper by Stapleton showed that 13 to 16 of the children with hypercalceuria are at risk of developing nephrolithiasis compared to 1.7% of children without this pathology. For the screening for hypercalceuria, the first step is to get a calcium creatinine ratio in random urine. Normal values are usually age dependent and are shown here on the table on the right. When the calcium creatinine ratio is elevated, then the test should be repeated, and if persistent, a 24-hour urine for calcium excretion should be requested to confirm the diagnosis. And a value above 4 milligrams per kilo per day or 0.1 millimoles per kilo per day, as I mentioned before, is considered abnormal. Our renal ultrasound should also be performed to rule out nephrocalcinosis, the presence of stones, and other tests involved are serum calcium, phosphorus, vitamin D, and parathyroid hormone. investigation on the patient's medical history should be also done in search of medications, for example, such as furosemide, that can increase the excretion of calcium in urine. And for the treatment of hypercalceuria, the management is usually conservative and involves mainly lifestyle changes such as dietary salt restriction and increase in the fluid intake. Thiazide diuretics can usually be used to increase calcium reabsorption in the distal tubule and reduce the renal excretion of calcium. And in the case of large urethral or renal stones, then surgical intervention can be required, as you know. Then moving on to urethral regia. This is a very important one because it's the one that very few people know about and that we get called about a lot. So urethral regia, or idiopathic mild terminal hematuria, is another frequent cause of gross hematuria in children, and it's commonly missed. Its presentation is most common on prepubertal boys with a history of terminal hematuria or spotting in the underwear between voids. It is usually benign and painless, although up to 25% of cases have reported dysuria in presentation. The etiology is unknown, and some of the theories suggest viral infections, hormonal imbalances, meatal stenosis, and dysfunctional voiding or elimination as an underlying etiology. It's important to know that all evaluation and tests tend to be negative, from labs to cultures to imaging. And the resolution usually occurs for more than 90% in less than a year. Actually, half of them self-limit in the first 6 months, and almost all of them are resolved in 2 or 3 years of time. Some groups have suggested different alternative treatments, such as bladder bowel management, increased fluid intake, and alpha blockers. A group from Spain, led by Inarejos in 2007, reported that they prescribed time voiding to all of their patients with urethral regia, and they yielded 100% of resolution in 2 years. So they prescribed actual time voiding to all of them, and these were their findings. Finally, one of the few complications in urethral regia are the presence of urethral strictures, which can appear even months or years after a bleeding episode, and it's discussed if they are actually iatrogenic or part of the history of the disease. So a couple of papers on urethral regia. This one is done in California in 1982 and followed 21 toilet-trained prepubertal boys with blood spotting on the underwear between voids or terminal hematuria during 11 years. And they found that most cases presented in winter and spring. The median age of presentation was 7 years old. The most frequent symptom, apart from hematuria or spotting of the underwear, was dysuria. All their labs and imaging were normal, and most cases resolved on their own in 6 to 12 months, although they did have cases that went on for as long as 80 years. One of their interesting findings was that strictures only developed in 3 patients, all of which had previous cystoscopies. Meanwhile, no strictures were developed in patients who did not undergo cystoscopy. This is another paper that actually focuses a little bit more urethral regia and urethral strictures. It's a retrospective review of 66 boys with urethral regia in a 15-year period. And they report that out of the 66 patients, 50 of them presented with classic symptoms of blood spotting in the underwear or terminal hematuria, while 16 patients presented atypically, and by this they meant gross hematuria, dysuria, or meatal stenosis and obstructive symptoms. 55% of the patients underwent cystoscopy in this study out of the 66. And the findings were classified in 4 different groups. 5% were found to have a normal appearing urethra. Half of the whole population had inflammation or hyperemia of the vulvar urethra. 30% had wide membranous exudate or mucosal irregularities, and 14% of them had stricture on the initial cystoscope, so on the first time that they were scoped. It's one of the interesting findings is that strictures developed after the initial cystoscopy in 6 of the cases, so 11% of them, but 8 of the patients, as I mentioned before, had a urethral stricture on the initial cystoscopy. So the author reports that those with initial strictures were clinically indistinguishable symptomatically from those who did not have initial strictures. So it's hard to tell. And they conclude that it remains unclear whether stricture formation occurs as a result of endoscopic trauma or as the natural history of a subset of the patients with urethral regia, right? They also, given the high rate of spontaneous resolution, they still propose a conservative approach to the diagnosis of urethral regia, right? Because more than 90% of them will resolve on their own without complications. So they suggest a management algorithm in which only boys that have persistent or recurrent symptoms or an abnormal uroflow finding should be candidates for cystoscopy. There we go. Okay, so the next etiology is glomerular nephritis. And glomerular disease represents a big chunk of the causes of hematuria in children, right? They can be either acute, subacute, or chronic conditions. And well, what usually tells them apart in the initial urine assessment is the presence of red blood cells cast, dysmorphic red blood cells, and proteinuria, which raise the flags for suspicions of glomerular disease. Other findings involve increased serum creatinine in urea and decreased C3 complement. The presentation of gross hematuria can be, the presentation of glomerular nephritis can be both with asymptomatic hematuria or other systemic symptoms such as hypertension, edema, and oliguria. And there is usually a previous history or concomitant history of infection. There is a wide range of glomerular nephritis, but for this presentation, we're going to focus only on the most common two, which are IgA nephropathy and post-rep glomerular nephritis. Other important ones that we're not going to get a lot into is Alport syndrome and thin glomerular basement membrane disease. So the two most common glomerular nephritis in children, oh, sorry, I forgot to mention, the prognosis of most glomerular nephritis in children is better than adults, but it's important to do an early diagnosis and refer them to nephrology promptly, so to delay progression and preserve renal function. So moving on to the main glomerular nephritis. So IgA nephropathy is the most common cause of glomerular nephritis in children. It's, well, both of them are more common in boys than in girls. And the presentation of IgA nephropathy usually involves an infection of the mucosal lining, which is typically GI or respiratory. The presentation with intermittent and recurrent episodes of microscopic hematuria or gross hematuria. There can be or not proteinuria. The BP and renal function can be normal at diagnosis depending on the time of diagnosis, but a small percentage of them will present with acute glomerular nephritis or nephrotic syndrome, and these kids are at risk of progression to complete renal failure after the onset of the disease. The treatment in IgA nephropathy is usually focused on delay the progression of the disease. And this is done by controlling blood pressure and prevent the formation of further immune complexes with the use of steroids. And acute post-streptococcal glomerulonephritis usually comes with a 1 to 3 history of throat or skin infections with certain strains of group A streptococcus. Peak incidence is around 7 years old. Again, it's more common in boys than in girls. It usually has acute presentation of hematuria, hypertension, oliguria with edema, and azotemia. And for these glomerulonephritis, symptoms usually subside in 1 or 2 weeks, although the microscopic haematuria and proteinuria can persist for months or years. The prognosis for this is usually complete recovery in almost all of the patients. Now moving on to tumors. So as I mentioned before in the previous papers, tumors represent a very tiny but important cause of gross hematuria in children due to the consequences. As shown in the multiple studies before, they only represent around 1% of the causes of gross hematuria in children. The two most common malignancies are Wilm tumors and urothelial tumors. In the context of hematuria, I mean. Wilm's tumor, as you know, is the most common malignant renal tumor of the infancy, and it occurs in 1 out of 10,000 children, approximately. And approximately 10% of these patients can present with gross hematuria. Then urothelial tumors are very, very rare in children. The most common of them being the papillary urothelial neoplasm. And we also have to consider benign tumors such as fibroepithelial polyps in the ureter, bladder, or urethra, which are very, very uncommon, but they present with hematuria in most of the cases. Some of them can also present with obstructive symptoms and producing UPJ obstruction. Nutcracker syndrome is a very small and rare case of hematuria. But it's an important one and another one of the ones that are missed, commonly missed. It's caused by the entrapment and the compression of the left renal vein between the aorta and the superior mesenteric artery. This results in hypertension and the development of collateral veins. And the presentation for these patients it's usually hypertension, intermittent left flank or abdominal pain, hematuria and or proteinuria. And in boys, it's related a lot of the times with varicocele, or in girls with pelvic congestion syndrome. However, similar anatomical configurations have been found in around 40% of children with asymptomatic microhematuria before, with no other identifiable cause. So that just shows that the Nutcracker syndrome a lot of the times is asymptomatic. So then, exercise and trauma are two other causes of gross hematuria. I will not go into trauma a lot because it's a whole different topic. But exercise-related hematuria is also known as March hemoglobinuria or exercise myoglobinuria. And the reddish tinted byproducts of hemolysis filter into the urine after some strenuous activity. That's the cause of the red brownish urine. The initial dipstick evaluation should be positive for blood, but microscopic analysis usually shows no red blood cells. However, exercise can be definitely also related to true hematuria, and this can occur through two mechanisms. One of them traumatic and is usually related to long distance running in dehydrated patients with empty bladders and the bladder wall suffering some recurrent trauma and producing small bleeding, and non-traumatic causes. And then finally, I just wanted to mention about trauma, that with findings less than 50 red blood cells, the likelihood of a significant lesion to the genitourinary tract are very low. But if the value is above 50 and we have the context of a blunt trauma, above 50, or we have gross hematuria, and we have the context of blunt trauma or a concerning mechanism of injury, like significant acceleration, deceleration, or the presence of shock, of course, then we have to consider internal bleeding and do a CT scan. Then to finish, some less common etiologies. One of them is sickle cell disease, where the hemoglobin S promotes some vascular occlusion and necrosis, and this produces hematuria or renal papillary necrosis. Also, sickle cell disease is associated with a higher risk of rare malignant medullary renal cell carcinoma, and this can be identified as a central mass, central renal mass on the ultrasound. Hematological causes always have to be looked for: thrombocytopenia, hemophilia, or coagulopathies, and interstitial nephritis secondary to medications. These are usually isolated hematuria causes, or are sometimes associated with proteinuria and reduced renal function. NSAIDs, protease inhibitors, penicillin, cephalosporin, phenytoin, cimetidine, etc., have been reported to cause interstitial nephritis. And in the majority of the cases, withdrawal of the medication results in resolution of the urinary abnormalities. This is a table obtained from the AUA guidelines on pediatric hematuria, mentioning some of the drugs that are associated with acute interstitial nephritis. So to finish this presentation, some of the messages to take home are that gross hematuria is uncommon in the pediatric population, and it's usually 1.3 out of 1,000 presentations of patients in the ER. And once glomerulopathies have been excluded, isolated asymptomatic hematuria in children is most commonly benign, transient, and self-limited. Associated proteinuria, hypertension, edema, or oliguria, or any other signs of systemic disease should always prompt referral to nephrology to make sure we provide timely treatment and avoid or delay the progression to renal failure if that's the case. Most of the literature reports that around 30 to 40% will have no clear etiology. The most common causes for gross hematuria in children are hypercalceuria, number one, followed closely by glomerular nephritis and UTIs. So they are mostly nephrological causes. Also, urethra regia is up there with glomerular nephritis and UTIs, and has to be considered because it's usually missed. Another important fact is that malignancies are very rare, but nonetheless very important. They represent around 1% of the causes of gross hematuria in children. And to avoid the overuse of unnecessary studies, the evaluation of gross hematuria should be based on clinical setting mainly. So obvious presentations such as trauma or acute pain, flank pain suggestive of stones might require specific imaging, but in most other cases, renal bladder ultrasound should identify most of the congenital urological conditions and malignancies. Cystoscopy finally should be reserved for cases of persistent hematuria or ambiguous imaging study findings. So that's the end of the presentation. These are a couple of topics that I thought were interesting or controversial for discussion. Do you guys think ultrasound is necessary for every single case of gross hematuria that we are called for? When do you do a cystoscopy? Are you more conservative? Do you like to scope all of your patients? And then the urethral regia management. What do you usually do with urethral regia, and what are your thoughts on this matter? So I open the discussion for all of our staff and colleagues and guests from every part of the world.
Thank you very much, Marisol. I've opened my mic. So Joana will, I think, give some comments and answer any questions. I've also asked our host to open the mic for some of our other urological staff here. A reminder that there's a Q&A box where you can ask a question. If you would like to ask a question out loud, you can raise your hand and we can open your mic for you. Yeah.
Hi, I think that Marisol, great job. I think that Darius asked about familial benign microscopic haematuria. This is a very common condition, I think underdiagnosed, we don't test it. Once in a while I see that in clinic actually. So those kids, they have microscopic haematuria in every single test. And when you test parents and you ask about the history of haematuria, they have it, it's absolutely benign. It's never accompanied by proteinuria and does not progress for chronic kidney disease.
Okay.
I'm not sure if Dr. Bagley or Dr. Lorenzo would like to give any comments.
Yeah, hi, this was really well done. Thank you. Just to comment on the intervention for urethral regia. My own teaching and one that I pass on was the only time really that cystoscopy was involved in urethral regia was way back when urethral regia was being discovered. I think at that point, it was understandable that scoping was being done because people didn't know what was going on. But typically, the appearance is when one does scope is believed to be a very sort of friable looking set of microcapillaries at the posterior urethra level, so that the turbulence of urine passing through this area causes them to be somewhat friable and opens up to some bleeding, not enough that you would see, but then when the urine flow subsides, some of that blood from those microcapillaries oozes out, trickles down the urethra, and comes out at the end as terminal hematuria, which is responsible for the spotting in the underwear, or they also talk about spotting on the rim of the toilet bowl. So I take that, I've always taken that as pathognomonic of this in the right age appropriate boy. And that's usually pretty typical as well. It's self-limited, it's benign, it's painless, it just requires reassurance. I can't remember ever having scoped anyone for that.
Okay.
And I certainly wouldn't use medication.
I would say that maybe for the persistent cases or typical cases, you know, and sometimes families get so anxious after 2, 3, 4 years of persistent hematuria that we end up indicating cystoscopy, but it's rare for sure.
And you have to balance that against the yield of the cystoscopy, which sort of then raises the question of doing procedures, particularly under an anesthetic in the child's case, to satisfy parents. It's one thing to do procedures to satisfy the medical practitioner, but it's a larger question of intervening in a patient, index patient, for other people, even if it's their parents.
I was thinking more about pointing out rare causes as, you know, AVM.
Sure.
Things like that.
Yeah. There
So
will
maybe
be. There will be instances.
Go ahead,
yes. No, it's okay. There will be instances, of course. No, nothing is ever 100%, but I'm just speaking generally. When you consider the fact that the Hospital for Sick Children, before my time, decades ago, when it was a 700-bed hospital, used to admit dozens and dozens of children preoperatively for cystoscopy the next day. So the amount of cystoscopy that was being done back then versus the amount that really needs to be done. And Joana, you're absolutely right. There may be instances where it is indicated. I just keep that sort of historical perspective in mind. But you're right, there will be instances. Go ahead, Armando.
So I think that just following with that, there is particularly in the older children, and these patients tend to be a little bit older and can tolerate it. It's very easy to do flexible cysto in the clinic. We have had, I think, pretty good success with that. And I agree, Joana, that this is for the patients who have persistent gross hematuria, because at one point you start wondering, is this really urethra regia, and am I missing something? And we've had a couple of cases where you see lateralizing hematuria, which will send you down a completely different diagnostic pathway. Maybe that leads into my next comment, is the ultrasound, maybe not the first one, but if you continue to worry and you want to look for more unusual causes, you have to request a Doppler evaluation for Nutcracker and for AV malformations and things of that sort. An ultrasound alone may not pick up on that, and the addition of Doppler assessment will help you ascertain that. The third thing that I'm going to say is that if there's ever a child that describes hematuria with passing of other stuff like little pieces of tissue, that goes, I mean, that should definitely be evaluated immediately with an ultrasound, because every now and then you'll see a Wilms tumor with urothelial extension, and that's how they present. They have hematuria and then they pass little fragments of tumor, which would be sad to be missed. And one little thing on physical exam, I can't remember if you mentioned it or Marisol or not, but when you're doing your physical exam in a child with hematuria, if you see a varicocele, the younger the kid, the more you should worry about varicocele. So a varicocele in a prepubertal boy in a kid with hematuria equals a tumor until proven otherwise, or a retroperitoneal mass or something until proven otherwise, because it reflects blockage or an impediment of the return of venous flow to the vena cava.
I did not mention that, but yeah, that's very important. Thank you.
I think if I can just make something, my experience of the kind of benign hematuria, the boys with the posterior urethra, and even in a way the Nutcracker syndromes, is, I agree with Joana that often these families and these patients are very, very anxious and very worried. And even though apart from the hematuria, they're essentially asymptomatic, their symptoms kind of are really bothersome to them. And I think this talk for me especially was quite reassuring in terms that the vast majority of them will resolve spontaneously, and that, yeah, you just need to kind of persevere with your counseling and your reassurance in those groups.
But maybe to add to that, Karen, so maybe at the risk of deviating a little bit, so what do you do with the child that has persistent hematuria? You do the cysto, the posterior urethra looks a little bit inflamed, but this kid is peeing blood and has been peeing blood for months, if not years. And there is a small but unfortunate group of kids like that.
I was hoping you would tell me.
Yeah, so that is hard, right? So the cysto in that case helps you confirm that there are inflammatory changes in the posterior urethra. And we're assuming that this is a child that has no comorbidities, right? It's completely different in somebody who's, say, immunocompromised, and then you think about viral things, and then you go down a completely different pathway. But it's completely normal child. Every now and then you'll get one, and what I've done in a couple of occasions, and it seems to help, is to put a catheter, sometimes put a little bit of steroid on the catheter. I leave it in for a few days, the idea being that the reason why they continue to do this is because this inflammation never ceases. The urine continues to kind of hit that area and flow, and it never completely heals. And then by diverting the urine for a few days, you allow that area to heal. And those patients that have the severe hematuria or persistent hematuria for a long time, and inflammation, irritation for a long time, in my humble opinion, they need to have a flow rate in follow-up a few times, because I think that those are the ones who develop strictures. It's not the cysto, it's what led to the cysto. So it's not that the cystoscopy caused a stricture, it's that people did a cystoscopy because they were at the wit's end, because the kid continued to have symptoms, so it was very symptomatic and stuff. And those are the kids that probably can develop a stricture, and you don't want to miss that.
Armando, what are your thoughts on Flowmax for those kids?
So I don't know, John. I tend to favor the use of Flowmax. It makes pharmacological sense to relax kind of that posterior urethra, and if this has to do with turbulent flow and a little bit of, maybe if you want to call it DSD, although it's not DSD really, it's dysfunctional voiding. that it could help a little bit. It's a medication that we haven't had many side effects and seems to be tolerated relatively well. And it could, in very selected cases where this persists, it could be worth a try. Again, because at one point these families are just very frustrated and they want to try something, right? They've been through a lot, but they get to us. So maybe the short answer would be yes, I don't mind trying it.
Yeah, I try to. Okay.
Yeah, I think thank you very much to everybody for attending. Like I said, this meeting will be has been recorded and we'll make it available. Furthermore, I'll send out a survey just to get your feedback on the webinar today. And for those people who would like access to some of the literature that Marisol used in compiling this talk, you can drop me or Mike or Marisol an email and we can get that to you. We'll keep you updated about further webinars. And yeah, thanks for attending and we hope you all have a good weekend.
Thank you, everyone.
Bye, guys.
Bye.
Thanks for joining.
Well done, guys. Thank you.